from there. So, all right. So sudden cardiac death in athletes is a very challenging topic. It's very charged because, I mean, these people die. And we're always left feeling like we could have done a little bit more. So I'm going to just go through some background causes and cases. So the reason why it's so difficult to decide on screening with athletes is that the incidence of sudden cardiac death in athletes is extremely rare, about 1 in 100,000 person years, roughly. And so most of the fatalities occur during sports, some outside of sports, and the survival is very low, less than 15%, but improving now that we have routine institution of defibrillators in the athletic field, so that these guys can, men and women, can be defibrillated in case of a ventricular arrhythmia, which is probably the most common cause of death, would be a fatal ventricular arrhythmia. But if you contextualize this against all the other things that kill boys and girls and young men and women before the age of 21, it's quite low. So, you know, injury by far is the most. Homicide and suicide, unfortunately, are very high up there. Cancer and other cardiac causes are much more likely than sudden cardiac death. So we're really it's a pretty uncommon, it's a real needle in the haystack that we're looking for here. But so what is this needle in the haystack? So this is a study published in Circulation about the causes of sudden cardiac death. And Barry Marin is an electrophysiologist, previously at UCSF, who has pioneered a lot of this work. So by far, the most common cause of sudden death in an athlete is hypertrophic cardiomyopathy. And unlike the 1 in 100,000 deaths that we have, hypertrophic cardiomyopathy occurs in about 1 in 500 people. So this is pretty common, and probably more common than we think. Anomalous coronary artery is number 2. Myocarditis is number 3. And arrhythmogenic right ventricular cardiomyopathy, as it's now called, or arrhythmogenic right ventricular dysplasia, that's the old name for it. In any case, that's the 4th leading cause. So hypertrophic cardiomyopathy, this is a picture. You see this really thickened, very thick interventricular septum, especially, and maybe some thickness in the lateral base, but really that septum tends to be where it is. So as compared to a normal heart, of course, the septum, very thick. And as you might imagine, the ability of an epicardial coronary artery to get adequate blood supply to that entire thickness of myocardium, especially under periods of stress, is very hard. And furthermore, there's fibrosis in that muscle. So here you see all of this fibrosis in this myocardium. And so this is very unhealthy muscle. If you look at the arterioles, they're often thickened as well. So there are various different reasons why this problem can exist. So now look at this echocardiogram and notice it's a fairly hyperdynamic heart, this left ventricle. So here's the left ventricle. Let me just do this. Okay. And you see this thickened septum really just squeezing against the posterior wall, probably mid cavity. It looks like there's some obstruction there, mitral valve. And when you look at this, it's subtle if you don't read echoes especially a lot, but there's some really turbulent flow. It's called aliasing. The flow is so fast that it exceeds the ability of the Doppler to capture it. And so there's this aliasing, and of course this is the substrate out of which ventricular tachycardia, monomorphic or polymorphic, can come as polymorphic ventricular tachycardia torsades. And so an athlete may have hypertrophy of their heart, but athletes tend to have symmetric hypertrophy more than asymmetric hypertrophy, more than just of the septum, more than the posterior wall. And the definition by the echocardiographic guidelines is 1.5 to 1 to call asymmetric left ventricular hypertrophy. Athletes rarely have hypertrophy greater than 17 millimeters, whereas in hypertrophic cardiomyopathy, 20 or even higher is sometimes seen and also associated with higher risk. An athlete's heart, the left ventricle itself dilates, and so the cavity dimension accommodates for a larger stroke volume, so that you can really, pump high volumes of blood to increase your cardiac output. Whereas in hypertrophic cardiomyopathy, typically the cavity of the left ventricle is smaller. So if you're looking at that echocardiogram report, maybe it'll say 3.9 is the end diastolic dimension, which would be low, something like that. Less than 4.2 generally would be low. Diastolic function in an athlete is typically normal. So we talked about this in previous talks, but the tissue Doppler hopefully is reported on a high quality echocardiogram report and should be more than 7 centimeters per second. And then strain is less used in echo, but always talked about. So there's a couple of things. So Hank Gathers, famous athlete with hypertrophic cardiomyopathy who died on the court, played for Loyola. Second leading cause is an anomalous coronary artery. So just to orient to normal coronary anatomy, the pulmonic valve is anterior to the aortic valve. So that's really important. The pulmonary trunk, of course, will dilate with elevated pulmonary pressures associated with exercise. So for example, horses, that pink frothy sputum at the finish line, their pulmonary pressures rise so much that they rupture their capillaries and they actually have bloody pulmonary edema. So anyways, just to illustrate that pulmonary pressures rise under normal physiologic circumstances. And then the aortic valve behind it gives off the left main coronary artery, which goes down to the LAD and the circumflex and the RCA, and that's normal coronary anatomy. So there's various anatomical abnormalities of the coronary arteries, during which the left main can come off in a different place, here or here, here. And all of these would be fine because as you see, if the pulmonary artery anteriorly does enlarge with exercise, it will not compress the arteries in all of these variants because they go around, of course. So this would be normal. As opposed to, for example, a right coronary artery that comes off of the left coronary cusp going in between the pulmonary trunk and the aortic valve. Same thing, left main coming off of the right coronary cusp, et cetera, et cetera, et cetera. So you can see there's a number of variants where sudden cardiac death would be unlikely, and a number of variants where sudden cardiac death would be likely. Because again, with enlargement of the pulmonary trunk, those things can happen. So this is Hank. This is Pistol Pete Maravich. He played for the Utah Jazz for years and years, and maybe he's sort of a dated basketball player, but played his entire career, no incidents on the court. He was playing a pickup game in retirement and died on the court, and was found on autopsy to have an anomalous coronary artery. So just some kind of famous cases of people who've had these types of things happen. And then, so again, most common cause of sudden cardiac death in athletes, hypertrophic cardiomyopathy, number 1 by far. Number 2 is anomalous coronary artery. Number 3 is myocarditis. So myocarditis is basically a viral inflammation of the heart muscle that it very much mimics exactly an ST elevation myocardial infarction, because there is myocyte cell death. It tends to be focal, and they may have a mild viral illness, but mid-sternal chest pressure, and typically, again, ST elevation on their 12-lead EKG during the time at which they develop myocarditis. And so here you see this large area of relatively large area of infarction anteriorly, and of course in this autopsy specimen. And then that sets up the potential, again, for ventricular arrhythmia, which would typically be polymorphic ventricular tachycardia. And so there's various pathological findings that define myocarditis. But Reggie Lewis, here pictured with Larry Bird, Reggie Lewis played for the Boston Celtics and died of myocarditis. I think there are some more recent cases, of course, and these things happen, unfortunately, not uncommonly. So there's, again, now the last, the fourth most common, and then you get sort of way down the list of the causes of sudden cardiac death in athletes, is arrhythmogenic right ventricular cardiomyopathy. And so in arrhythmogenic right ventricular cardiomyopathy, you see a very enlarged right ventricle, but also a lot of fibrosis and scarring. Tremendous amount of this is inheritable. This is congenital type of thing. It is a pathology with linking the cardiac myocytes, and so that protein's affected. As you can tell in this case, there was free wall rupture. So the right ventricle ruptured, bled into the pericardial space, tamponade, and immediate death. So in arrhythmogenic right ventricular cardiomyopathy, you'll see anterior T wave inversion, and also, very importantly, this delta wave. You'll typically see a delta wave. So if you don't see that delta wave, very, very commonly, you'll see a young athlete, typically less than 25, who will have this anterior T wave inversion. And I see this not uncommonly in these types of people who have persistent juvenile T waves. In that case, my recommendation is to check an echocardiogram and make sure they do not have right ventricular enlargement. If their right ventricle is normal in size and they have anterior T wave inversion, it almost always is persistent juvenile anterior T wave inversion. If they've had syncopal episodes or have some other cause for concern, at that point I might proceed with a Holter monitor, exercise treadmill test, or something else. But if there's no other reason to check those testing, I personally will keep it at an echo, because again, anterior juvenile T wave inversion is pretty common, and you're gonna see it if you see enough 18 to 20-year-olds and do a lot of EKGs on them. But again, you need to keep in mind that this very rare phenomenon of arrhythmogenic right ventricular cardiomyopathy is possible, and very dangerous, of course. Now here you can also see, interestingly, some probable left atrial enlargement, maybe right atrial enlargement. You know, there's some other things about this EKG that would definitely merit an echocardiogram, especially in a younger person. So this is an Italian soccer player, Antonio Puerta, and he died on the field from ventricular tachycardia as a result of arrhythmogenic right ventricular cardiomyopathy. So this kind of leads into a sort of broader discussion, and as some may know, Colin Fuller is talking tonight about screening of athletes with 12-lead EKGs, which is presently recommended against by the American College of Cardiology. However, in Italy, they do routinely screen all of their athletes with a 12-lead EKG. And furthermore, they have shown that by screening with a 12-lead EKG, you can prevent death in their athletes. So they've longitudinally done it, and they have lower rates of sudden cardiac death during exercise with a program that involves screening with a 12-lead EKG. And the reason I believe why that is true is that they have higher rates of arrhythmogenic right ventricular cardiomyopathy, and they find that those people, and they, you know, appropriately get them therapy and take them out of sports, which is very challenging, and things of that nature. But in the United States, we have a much higher African American population, and so what we're going to see, African American men who play basketball are going to be the highest risk of sudden cardiac death in sports. And these men, if screened with a 12-lead EKG, if they have hypertrophic cardiomyopathy, you're going to see you're going to see left ventricular hypertrophy. You should do an echocardiogram, invoke the criteria that I cited for deciding whether they may or may not have hypertrophic cardiomyopathy. At that point, my recommendation would be first to counsel them, and then to do genetic testing, because genetic testing we have currently available, and you can basically, there's a large number of very well-defined variants of hypertrophic cardiomyopathy, and those people should know about because they have heritable patterns, and the anatomical, you know, the true extent of their hypertrophy may only come out into later in their, you know, early adulthood or later in life. So what patients need to know about genetic screening for hypertrophic cardiomyopathy is that if they have a genetically proven hypertrophic cardiomyopathy, they cannot fly a plane ever. And they can't drive a big rig truck. If they're found out to have those things, and that happens, they can have their license for either revoked, and then, you know, maybe other disciplinary action. So it's very tricky, because, you know, you're talking to a person who probably is 25 or less. Their career is all in front of them, and who knows what they're going to do, and you're going to eliminate those possibilities. So as I was telling Sharmisa before we started, I have a personal example of a close friend who's a family member has known hypertrophic cardiomyopathy, and this friend's son is syncopized during a baseball game, and he went to the ER, had a 12-lead EKG, had a bunch of left ventricular hypertrophy. He was a young kid, and I said, you got to get an echo. Of course, I can't break that. I can't violate the confidentiality of my patient, who's the family member, by saying, you know, because his family member has hypertrophic cardiomyopathy and there's a presumed genetic link. And so then we did genetic testing, and the rest, it became, you know, a very challenging thing to deal with. But again, you know, whether you test that child for the hypertrophic cardiomyopathy, you know, you may have to weigh a lot. The workaround that I have is to say, well, if this child has no significant left ventricular hypertrophy, but that one of the parents you have to look at the inheritance pattern. A lot of times it'll be autosomal dominant, has that gene for hypertrophic cardiomyopathy, I'll test the parent and then would presume that the child has that gene, and then know that we need to serially test them, etc. But then you have to think about defibrillators and all these other things. So I think that it does involve some complex family discussion, knowing that they can't be a commercial driver or pilot if they are shown to have hypertrophic cardiomyopathy. And furthermore, we don't know how many people who have the genetic variants for hypertrophic cardiomyopathy exist in the population, because we don't have population genome-based screening, broad-based genetic data for the population and correlation to that with known pathology. So in other words, we know that people who have the physiologic, the phenotypical manifestation of, for example, hypertrophic cardiomyopathy, tend to have one of these number of genes, but we don't know how many people without the phenotypical manifestation of hypertrophic cardiomyopathy exist in the population, so the denominator. Anyways, tricky cases, very challenging thing to do, and I highly invite any commentary, because I think this is, once you send them to a genetic counselor, that counselor is almost always, in my experience, going to tell them that they should not, for example, participate in activities like truck driving and things like that. So once you get them to that step, that decision's pretty much been made for them. They will be counseled against truck driving or flying in the case of hypertrophic cardiomyopathy. So, and furthermore, I've had other examples where we've, had sudden cardiac death outside of the athletic field, and then we talk about if we find things like ventricular tachycardia, then maybe you put a defibrillator in that person, and if they have an internal defibrillator, in some circumstances, they may be permitted to still participate in athletic competition. But you need a lot of opinions to make that kind of decision. As one of my mentors once told me, never carry a casket alone. That's a little morbid, but it's true. Never carry a casket. I mean, if you're dealing with high-risk stuff, you need some opinions on the table and a consensus. I think that's the right management strategy. So, you guys have any thoughts about that? Screening these young people with potential hypertrophic cardiomyopathy and the implications into their life and work career and things of that nature. Generally, we still let them drive themselves. I mean, people with defibrillators still drive themselves. If they syncopize, then their license needs to be pulled for a period of 6 months. And then, of course, they can no longer drive. But we don't just take the license out of the hand of anyone with a defibrillator either. So, there's a lot of nuances to all that. I think a lot of ethical nuances to these things. So, all right. Well, if we don't, I think those are some of the salient cases. Remember, when you're doing this physical examination of these young athletes, and you're thinking that the number one thing that they could have is a hypertrophic cardiomyopathy. Some of the earliest studies before we had all this technology that we use now were just with the physical examination. So what you want to do is palpate their precordium and make sure that they don't have a thrill or a heave of those natures. I would recommend that be part of the physical examination for screening of an athlete with potential for pre-participation screening for prior to competition. And I will say, having been an athlete personally, including at the University of Nevada, I never had anyone palpate my precordium in a pre-participation physical examination, which is in light of the fact that the most likely cause of sudden cardiac death is hypertrophic cardiomyopathy, and there's only one way that you're probably going to find that on a physical examination. I would highly recommend that. Of course, if you think, so going back to that, maybe we can just pull that slide one more time. If you go back to this idea, the other thing that you want to listen for with hypertrophic cardiomyopathy is when you have this outflow tract gradient, it's going to pull the anterior leaflet.
Can we pause it?
No, it's okay. It's going to pull. Now can you pause that? So here's the anterior leaflet of your mitral valve. This hypertrophic septum will pull this anterior leaflet up, and that often will create mitral regurgitation. And so obviously if you hear a systolic ejection murmur of associated with the dynamic left ventricular outflow tract gradient, HOCM, or a blowing systolic murmur associated with mitral regurgitation, those would be a couple of reasons to check an echocardiogram in the pre-participation evaluation of an athlete. So a couple of things that you can, palpating the precordium isn't the only thing, but you got to be kind of far down the line before you get mitral regurgitation and a big outflow tract gradient. You have to have a lot of hypertrophy to get there. So, all right. Well,
yeah, Dr. Van Gilder, please.
Oh yeah, please.
Hi. So in filling out the forms that we have for these pre-participation physicals, it's pretty basic, of course, and it really asks about murmurs and is there a murmur greater than this?
Yeah.
And I went to UNR and I was trained in medical school there, and we are trained to palpate the precordium in a general exam, but I never was taught that in the pre-participation physical, so it's very helpful. Thank you.
Yeah.
Is there any maybe place for that to be put on the form?
Yeah, I think that we can look at that. Colin Fuller puts that thing together, so I'll maybe send him a note on that. But I think that, so I also went to the medical school at Nevada, and I went through the general university too. So I was an athlete, and I saw, at the family medicine clinic, and I know all those people, and I know, I understand that process, but there's more to it. So, there's just more to it than all of that. And I think that part of the greatness of being a practitioner of medicine is that we always have to push ourselves to move to the next level. Mm-hmm. And just because that's where we've been in the past doesn't mean that we can accept the limitations of that in moving into the future. And if there's a practical way to do that, then we should get it done. But I will say that we need to, you have to be a little bit comfortable with palpating the precordium of people in general. Mm-hmm. I often use the heel of my hand because I think it's a little bit more sensitive than my fingertip. Some people feel the opposite, so you just have to know your own hand, and generally it shouldn't be more than a quarter size, the point of maximal impulse. It should generally be around the apex of the heart. So if it's rotated over laterally, that's often consistent with left ventricular hypertrophy. And the other thing that I do, which is weird, but since I'm a cardiologist, is after I exercise, I'll palpate my own precordium because I can feel a really good thrill. Most people will have a thrill because of the increased contractility after you do maybe really rigorous exercise. Usually I can feel that best after, for example, lunges, where I'm doing more resistance exercise, but not so much cardiovascular exercise. So, but I mean, you got to train yourself and feel that exam is reliable before you can, apply it to patients. But yeah, I'll talk to Colin about that. I talked to him about the whole pre-participation thing in general, but again, he's been driving this for a long time, and he practices a little bit. I think he wants to be cutting edge, and he does it because he had a young man die on the field after an examination. And so I get that I understand the purpose of his crusade, but it's not perfectly in keeping with the data that the rest of electrophysiologists who study this have collected in the United States population. But I think genetic screening is going to change all that. I'll just say it like that. I think genetic screening is going to change that. So that's it. Anyways, thank you for the discussion. Everybody have a happy holidays, and be well.
Thank
See you guys in January. Thank you.